మీరు కనుక ఫస్ట్ టైం మా ఛానల్ చూస్తున్నట్లయితే లైక్ చేయండి, షేర్ చేయండి, కామెంట్ చేయండి. ప్లీజ్ సబ్స్క్రైబ్. మేము అందించే లేటెస్ట్ వీడియోల నోటిఫికేషన్ కోసం పక్కనే ఉన్న బెల్ బటన్ని ప్రెస్ చేయండి.
Hello, I am Dr. Shakuntala Ghosh, Senior ENT Consultant practicing in Hyderabad. I am a Director of Sri Rama ENT Care Center. So today I am going to speak about a very common topic which is called vertigo. So basically let us find out what this vertigo is. Vertigo is actually a sensation of movement of either the self or the surroundings, our environment, and it can be either a spinning or rotatory type, or it can be a simple imbalance, or a kind of a sensation of walking on some cotton wool where the ground is not firm and we tend to sway and lose our balance. So these are the different sensations which we describe. So basically vertigo is thought to be as a diagnosis, but it is not a diagnosis, it is only a symptom, and the cause can be varied. So mostly when a patient presents with this vertigo, which is commonly in common terms we call it as giddiness or a spinning sensation. Vertigo is the medical term for it. So when a patient presents with such symptoms, they normally consult a neurologist, because they think that it is something related to the brain, the spinning sensation. But actually in practice we see that 70% of cases of vertigo are related to the balance organ which is present inside our ears. So basically if I talk about the physiology of this balance system, so let me explain it in simple words. Balance is when we are able to stand straight on our two feet without having either standing straight and stationary or while moving, that is we maintain our body equilibrium and balance without tending to fall to one side or sway, and we are aware of the environment, and we are our body is in coordination, or is it's in synchronization with the outside environment. So for this to happen, there are three basic organs which work with each other. That is, first is the vision, the eyes. They actually create the sensory input of visions. That is, we know that what is around us and what we can perceive, and these sensory inputs are sent to the brain. The second organ is proprioception. Proprioception is basically there are certain receptors which are present in our joints and in the muscles. They make us aware of where we are standing or sitting, or what our body position is. So that is called as proprioception. And the third is basically the vestibular apparatus. Vestibular apparatus is basically the balance organ which is present in the inner ears on both the sides. So these three organs work in tandem, and then the inputs, the sensory inputs from these three organs are sent through the nerves inside our brainstem and then to the brain, and that itself controls the sensation of balance. So that is when all three are working well, then we are well balanced. We do not face any giddiness or vertigo. But when the sensory input from any one of these three organs, that is the visual, the proprioception, or from the vestibular apparatus, when there is an imbalance in the sensory inputs from any one of these three organs, then the brain will sense it, and that will create a sense of imbalance which we call as vertigo. So what basically happens, let me talk about the vestibular apparatus first. So vestibular apparatus contains certain organs such as the semicircular canals and the cochlea, and the semicircular canals will contain certain fluids that is called as endolymph, and which the movement of the endolymph due to either movement, change in the body position, or movement of our body itself. So the endolymph will sense this movement. There are certain fine hair cells called stereocilia which are present within the semicircular canals, and they will detect the movement, and they will interpret this information and send it to a vestibular nerve which arises from the semicircular canals and the vestibule, and that nerve will carry this information to the brainstem. The brainstem has a certain center which is called as vestibular nucleus that will perceive these sensory inputs, and that will again relay the information to the, so that cerebellum is a final center which perceives the balance, and that will again send inputs to our limbs, to our eyes, and then to the proprioception, and then maintain. So when we see that patients come to us with vertigo or imbalance, the fact that which we usually do not know is that 70% of this imbalance or these disorders of vertigo or dizziness is due to problems in the balance organ present in the ears. So basically, what are the symptoms of vertigo? So suddenly we are all right and suddenly we wake up in the morning, or we wake up in the middle of the night when we want to go to the washroom or something, and we experience a sudden very severe rotatory sensation, spinning sensation. Either our head goes round and round, or the environment spins around us completely, and we cannot control ourselves, we tend to fall. So that is the sensation. We do not lose consciousness, but we have the feeling that we will lose our balance and tend to fall. So immediately we close our eyes and lie down. So that is a common presentation. The other common presentation is we are all right and suddenly we have got up from bed, or we are sitting or we are walking, and we feel a kind of a swaying sensation or a certain blackout sensation, and we tend to sit down or take some support and sit down. Sometimes these symptoms are associated with a feeling of nausea, or sometimes we can have severe vomiting also. Then sometimes we may have some symptom like fullness in the ears or a ringing sensation in the ears. We can also have decrease of hearing. Then we can have sweating and a general feeling of discomfort. So these are the accompanying symptoms with vertigo. So when a patient comes to us, then how do we diagnose what could be the cause of vertigo? So commonly, like I said, that we tend to go to a neurophysician when we are presenting with such symptoms of vertigo. So a neurophysician will basically examine the patient and take a history and ask for any history of hypertension or diabetes or any thyroid disorders or any history of any previous heart disorder or previous history of stroke. And based on these things, he will refer usually to an ENT specialist for further evaluation, thinking that it could be related to some cause in the ear. So that is how a patient usually comes to the ENT specialist after having a routine checkup by a family physician or a neurologist and having ruled out the other causes of vertigo, like a cause in the brain or a general systemic disorder. So when the patient comes to us as an ENT specialist, we take a detailed history. So we ask the patient whether the onset of vertigo was sudden or was it insidious, slow, and whether it is gradually progressive or it is very severe with severe incapacitating vertigo when the patient is having such a spinning sensation that the patient is not able to sit or stand or do his normal daily activities. He has to lie down and take rest. Is it accompanied by bouts of vomiting or nausea? Is there any ringing sensation in the ears? Is there any decreased hearing? So these are the history we take. And most importantly, whether the vertigo is related to a certain particular position, when the patient is lying down or turning to one side in the bed, or when the patient is looking up or looking down, or whether the patient is on bending down. Is the vertigo being triggered by movement or change in position? So that is called as a positional vertigo. Or is it happening at any time when the patient is either lying or sitting or walking? Or does the patient have any imbalance or tendency to fall, or is having a kind of a gait which is a kind of an unsteady gait, that is the patient is not able to walk in one straight line, he tends to sway or fall to one side. So these are the history that we take, because that will lead us to the diagnosis. History taking will lead us to 80% of the diagnosis, then followed by an examination, and the tests which we order later on are only supportive. So a detailed and a proper history taking is very important in a case of vertigo. We have to spend time patiently and take the history from the patient, because patient will be very anxious and he might tend to exaggerate the symptoms, and so we have to ask them leading questions as an ENT specialist to extract the correct diagnosis of the vertigo or the cause of vertigo. So as I mentioned earlier, that vertigo can be of two types. It can be peripheral, which is 70%. That is related to the ear, that is the balance organ, the vestibular apparatus which is present in the ear. So vertigo can be that, or it can be 30% due to a positional vertigo, that is called as Bpvp. So in such a case, the classical presentation will be that the patient is lying in bed and suddenly he tries to turn to one side, either the right or the left, and that will trigger a severe rotatory vertigo, spinning sensation, which will last for less than a minute, about say 20 seconds or 30 seconds maximum. And patient may have associated nausea and vomiting sensation, and the vertigo attack subsides immediately after say about half a minute. Then the patient is able to lie down normally, and then when he gets up and does his daily activities, it does not have any vertigo. and this will be repetitive, that is particularly triggered by lying down in that particular position, either right or left, and the patient will not have any other accompanying symptoms like decreased hearing or tinnitus or imbalance while walking or sitting or any unsteadiness of gait. The patient will not have any other symptoms like headache. So that is a classical presentation of BPVV or benign paroxysmal positional vertigo. So when the patient comes to us with this kind of a history, then we do a particular maneuver to find out whether the patient is having BPVP, and that maneuver is called a Dix-Hallpike test. That is, we make the patient lie down at an angle of 45 degrees with the head bending down and tilted to one side, first to the right and then to the neutral and then to the left. And so the particular position in which the BPVP is happening, that will lead to a severe onset of vertigo. At the same time, the patient will have a vigorous movement of the eyeball to the affected side. It is called in medical terms as nystagmus. And that eyeball movement will also occur for about half a minute or maybe 10 seconds, after which the patient says that his vertigo has subsided and he feels comfortable. And then when the patient is made to sit up or to lie on the opposite side, he will not have any symptoms at all. So that is a Dix-Hallpike test, which is a characteristic test which is used to diagnose BPVP. Now, what is the pathophysiology behind BPVP? So BPVP is basically, there are certain semicircular canals, the 3 semicircular canals which are present in the inner ear. So these are the semicircular canals, the posterior, the lateral and the vertical semicircular canal. So in posterior semicircular canal, which is the main cause for BPVP, there will be certain calcium particles called otoconia, and they are supposed to be present in a cup-like structure called the cupula. So in BPVP, these particles are displaced and they will be floating freely in the semicircular canal. So when the patient lies in that particular aggravating position, which is either right or left side, then these particles will come out of this cup and float freely in the canal, and this will lead to a perception of vertigo. And when after some time the particle settles down and comes back to the cupula or the ampulla of the semicircle, we do as a treatment, we basically do a procedure which is called as an Epley's maneuver. That means first we find out which side is affected, and then we make the patient lie down on that side at 45 degrees, and then we slowly change the position of the patient's head by 45 degrees, first to neutral and then to the opposite side. That is, each position we maintain for about half a minute. And so once that means what we do is, whatever otoconia or calcium carbonate particles which have been displaced from the cup of the semicircular canal and are floating freely, we bring them back into the cup by this maneuver. This is called as a Simon's or an Epley's maneuver. So by that procedure itself, the patient will be relieved of that vertigo, and then we ask the patient to take rest for about, say, 1 week in a position at 45 degrees and we ask them not to lie down in the aggravating position for about a week. So that will lead to subsidence of the vertigo. Sometimes the patient will have a rebound and recurrence of vertigo. In that case, we repeat the Epley's maneuver. So that is the only treatment for BPVP. So easy to diagnose and an easy to treat condition. In the meantime, for 1 week, we put the patient on some sedatives, vestibular sedatives, to give the patient relief and ask him to take rest. Also, what could be the cause of this BPVP? In most cases, it is an unknown cause. Sometimes it may be due to a head trauma. That is, patient has inadvertently banged his head against against a door or against the wall, or has fallen down. So such incidents can also lead to displacement of those calcium carbonate particles from the cup of the semicircular canal and make it float freely in the canal in that particular aggravating position. So, but in other cases, mostly the cause will be unknown and it will settle with medication and with this Epley's maneuver. Now we come to the second important cause of peripheral vertigo, and that is called as vestibular neuronitis, acute vestibular neuronitis. So basically, as we can see, that this is the external ear and this is the middle ear and this is the inner ear. So in the inner ear, we have the semicircular canals and the cochlea. And then this is basically the inner ear structure. From the inner ear, there will be a nerve called the vestibular nerve, which arises from the inner ear and goes to the brain. So this vestibular nerve can sometimes be affected by viral infection, and this condition is called as acute vestibular neuronitis. So in such cases, the patient will have a presenting symptom of severe vertigo, which is incapacitating, associated with vomiting, nausea, sweating, and the patient will have to lie down almost bedridden, and this attack may last for a few days. So suppose the infection spreads also from the nerve to the labyrinth, to the membranous labyrinth, that is the cochlea and the semicircular canals, the viral infection can spread here. The patient can also have associated decreased hearing. So because it is a viral infection, it is a self-limiting condition. So within a few days, the patient will have relief. So the diagnosis is made by the ENT specialist by doing two particular tests. One is a pure tone audiometry, which will show us whether any involvement of the auditory part, that is the cochlea, is involved, that is a hearing loss is present. And also we do a simple caloric test to find out whether the vestibule has been involved. So there will be a hypofunctioning of the nystagmography, which will help in further diagnosis. But the presentation is very typical, that is, the patient will be all right till a few days back, and suddenly the patient will wake up in the morning with a feeling of severe vertigo and associated with vomiting and nausea, and the patient will have incapacitating vertigo lasting for about a few days, which will settle with complete bed rest and medication. The medication which we give is certain vestibular sedatives, the labyrinthine sedatives, which can be diazepam or other things like cinnarizine or meclizine or prochlorperazine, which will control the symptoms of vertigo as well as nausea and vomiting. And with this and complete bed rest, the patients will be absolutely normal in a few days. So this is the second common cause of vertigo, which is called as acute vestibular neuronitis. Now we come to the third cause of peripheral vertigo, and that is Meniere's disease. So what is Meniere's disease? Meniere's disease will occur either in 1 year or both the years, usually in the age group of 40 to 60 years. In some cases it may not be inherited, it may happen primarily. And it usually occurs in the middle age, and it affects either 1 year or both the years. And basically the pathophysiology in this Meniere's disease is basically the inner ear, that is the cochlea and the semicircular canals, will contain a fluid called as endolymph. So this fluid, sometimes in Meniere's disease, there will be an excess formation of the fluid within the inner ear, that is the vestibular apparatus and the cochlea, and that will lead to an increased pressure of the fluid which is present in the inner ear. And that increased pressure will be perceived by the patient as a severe onset of vertigo, that is a giddiness or spinning sensation. The patient will also have a feeling of tinnitus or ringing sensation in the affected ear. There will be continuous ringing or buzzing sensation in the ear during the attack of vertigo. Also a sensation of oral fullness, that is a sense of fullness in the ear because of the increased pressure of the fluid in the inner ear. The patient will have a sensation of fullness in the affected ear. And the fourth symptom will be nausea and nausea or vomiting. That is the fullness, the ringing sensation, and there will also be a sensation of decreased hearing or ear blockade, the vertigo. The episode of the vertigo will last for minimum of 20 minutes to a maximum of 12 hours. And it will occur repeatedly. That is, one single episode of vertigo will not help us in diagnosing Meniere's disease. There should be at least 2 or more such attacks over say 15 days, once in 15 days or once in a week. So when these classical 4 symptoms are there of vertigo, tinnitus and decreased hearing, oral fullness or fullness in the ear associated with or without nausea or vomiting, lasting for about 20 minutes to about 12 hours and happening recurrently, and the symptoms may be either related to 1 year or in 30% of cases it may be in both the years. Mostly in a middle-aged patient who was all right before and then suddenly develops these symptoms without any history, other previous history, then we diagnose Meniere's disease clinically. And then we subject the patient to some tests which will help us in clinching the diagnosis, and that test is called a pure tone audiogram, which may show a mild to moderate hearing loss in the low frequency or middle frequency, either in 1 or both the ears, and that hearing loss will be sensory neural hearing loss. Also, we do a test called CHAMP test, which is an electrophysiological test, and that will show whether the vestibular organ on the affected side is involved. So the CHAMP test or an electrocardiography. So the treatment of this condition, Meniere's disease. So basically in Meniere's disease, we try to reduce the pressure of the endolymphatic fluid which is circulating in the inner ear. And how do we do that? We ask the patient to take a low salt diet, so reduce the salt intake. Because like any other, like a high blood pressure, we ask the patient to take a low salt intake. So similarly in this also, the salt intake reduction will reduce the endolymphatic fluid pressure in the inner ear. Also there are certain diuretics like hydrochlorothiazide or acetazolamide which can be prescribed. And then symptomatic treatment of the vertigo. So when the patient gets an attack of vertigo, then we tell the patient to take certain labyrinthine sedatives like benzodiazepine, meclizine, cinnarizine or prochlorperazine, which will take care of the vertigo and the vomiting episodes. But usually these episodes are self-limiting, that is, it will last for a few hours, and then the patient, when he has vomiting, then the vertigo subsides and the patient feels absolutely normal till he gets the next attack. In between, the patient will be able to carry out his daily activities, and it is not related to any particular position or any change in position or movement. The patient will not have any symptoms till again the pressure in the endolymphatic fluid increases and the patient gets a next attack. Unfortunately, repeated attacks of Meniere's disease will cause to permanent hearing loss in the affected ear, and also the patient may have attacks of vertigo which may persist for a few years together. So the treatment will be basically treating the symptom as such, but there is no permanent solution to this condition. But usually pharmacological treatment and low salt intake will reduce the frequency of the attacks and the severity of attacks. But in some cases, medicines and low salt intake will not take care of the vertigo. The patient will have incapacitating attacks, increased frequency, it will affect his lifestyle, and in such cases the patient will require surgery. That is, there are some surgeries which will destroy the membranous labyrinth, that is the inner ear, and will basically the seat of the disease, that is, and that can be done chemically by giving injections of gentamicin through the eardrum or the tympanic membrane, which will slowly destroy or reduce the function of the membranous labyrinth, that is the vestibular organ in our ear. Sometimes even that doesn't help, then we'd have to do certain surgeries such as endolymphatic sac decompression or vestibular neurectomy or even labyrinthectomy. So these destructive procedures can be done in cases who are elderly loss or so, in elderly individuals, and who have incapacitating vertigo which is not getting treated adequately by medicines or by low salt intake. So in such cases, surgery is the last choice. But the side effect of surgery will be that the patient will have permanent hearing loss, although his vertigo will disappear permanent. So that is the third condition. So these acute vestibular neuronitis and Meniere's disease are the most common causes of peripheral vertigo, and they can be treated very well by an ENT specialist. There are other common causes of peripheral vertigo that is called as cervicogenic vertigo. So cervicogenic vertigo is due to cervical spondylitis, that there will be acute spasm of the muscles in the nape of the neck or the root of the neck due to faulty position, or sometimes because of our lifestyle problems, like when we tend to look at the screen, the computer screen, or look at our mobile phones for very long durations, for hours together, by bending the neck, or those who travel frequently, and then that can also lead to spasm of the neck muscles. Those who have severe cervical spondylosis, which is a degeneration of the cervical vertebra, which is present usually in old age, even that can stimulate the vertigo. So that is a cervicogenic vertigo. So this can be corrected by postural changes, using a cervical pillow and cervical collar, soft, and also isometric neck exercises. Chronic vertigo can also be taken care of by vestibular exercises, which will actually recondition our brain to the fact that one side of the vestibule, that is either right or left, is hypofunctioning. So basically the brain will try to compensate by increasing the function of the opposite side vestibule and produce a kind of a balance between the under-functioning and the over-functioning vestibule. And then the patient will not have a sense of imbalance or vertigo over a period of time by certain exercises of the eyeball, the head, the neck, and the body. These are called as vestibular exercises, and in the long term they will help us in overcoming the problem of vertigo, chronic vertigo. Now we come to the other cause, that is central vertigo. That is 30% of cases, the cause can be due to some lesion or pathology in the brain. This can produce vertigo, and this is quite a sinister condition, and this has to be ruled out. So basically, what are the causes? 3 or 4 important causes of vertigo due to the central cause, or that is the brain and the brainstem. One is vestibular basilar insufficiency. That is because of old age, the blood circulation in the posterior circulation of the brain, that is the vertebrobasilar artery, that will be reduced because of narrowing or stenosis of the vessels, blood vessels, due to atherosclerosis, etc. So that can lead to decreased blood flow to the brainstem and the cerebellum, which are the organs which are related to the balance in the brain, and that can lead to vertigo. The other common cause is a posterior circulation stroke. That's the ischemic stroke, that is a thrombus and embolism which will suddenly block the blood flow in the vertebral arteries and the basilar arteries which supply the cerebellum and the brainstem. So suddenly the patient will have a posterior circulation stroke leading to vertigo. The third cause could be some tumor which is present in the vestibular nerve or the auditory nerve which is entering the brainstem, the cerebellopontine angle region. So it is a vestibular schwannoma or a cerebellopontine angle tumor. So some brain tumor which is causing pressure on the nerves, or it can be inside the nerve, or it's causing pressure from outside and leading to the symptom of vertigo. So that is called the cerebellopontine angle tumor. So an intracranial tumor which can be a cause of vertigo. And the fourth important cause can be vestibular migraine. So vestibular migraine is a rare cause, not a very common cause, but that can also be a cause of vertigo. And there are some other causes such as trauma to the neck or to the brain, to the brainstem, and that can compromise the blood supply, or it can cause some grievous injury, and that can also lead to vertigo. These are the rare causes. So these are the central causes of vertigo. Then there are other causes of vertigo which is not classical vertigo. Basically the patient will have a sensation of a kind of a blackening or a darkness in front of the eyes when the patient is getting up from lying down or sitting position. That can be due to postural hypotension, a syncopal attack. So that the patient can perceive as a vertigo or a reeling sensation. It is not the classical spinning or rotatory type of sensation. It's a non-rotatory vertigo. It's just a blackening sensation, or the patient can have sweating and a feeling of imbalance when the patient gets up. So the second cause can be anemia. Anemia can also lead to a sensation of vertigo. The third cause could be hypothyroidism. And the fourth cause could be vitamin B12 deficiency, that is methylcobalamin deficiency, which can lead to a generalized neuropathy leading to a sensation of vertigo. So these are the non-vertigo causes. I mean, it is neither a vestibular cause, neither is it an intracranial cause. It is basically a sensation of vertigo, but it is not classical vertigo. But the patient may get confused and present as a vertigo, and that can be ruled out by a detailed history, thyroid levels, vitamin B12 assay, and generally a basic checking the blood pressure, etc., and taking a detailed history. So how do we treat vertigo? So the treatment of vertigo again will depend on the cause of the vertigo. So a very important detailed history is important, that is the onset of vertigo, whether it is sudden or it is insidious. Then how long, the duration of vertigo, whether it is for a few seconds, few minutes, lasting for a few hours, or is it a general unsteadiness or a continuous feeling of vertigo. For example, I said in the central vertigo, the symptoms will be persisting for days together, and the patient will not get any relief in between. It is not related to a few seconds or minutes. The patient will have a sensation of imbalance either during walking, sitting, standing, etc. And it may not be associated with vomiting or a nauseous feeling in case of central vertigo, whereas in case of peripheral vertigo, the patient will classically present with nauseous feeling, vomiting, lasts for few seconds to few minutes to few hours. The patient will be normal in between, or it may be related to a particular position like lying down, lying to one side, right or left, or when bending the head or looking up, or it can be due to some kind of other cause like like in Meniere's disease, it is not related to position, but the patient will have a very classical presentation. So a detailed history will help us in diagnosing that, and then we examine the ears, the nose, throat and all, and then we do some basic tests. We make the patient walk. Audiometry will show whether there is any sensory neural involvement, that is involvement of the cochlea, etc. And then we ask for caloric test, which will show whether there is involvement of the vestibule. We ask for electrocochleography or a VEMP test, that is a vestibular and evoked potentials. Then also ask for ENG, and also then we ask for a CT scan or an MRI brain to rule out any cause if we suspect that it could be a central cause of vertigo. That means classically the patient will be present with ringing sensation in the ears, decreased hearing, and also vertigo attacks which are repeated, and there may be some kind of an oral fullness. There may be associated symptoms like, for example, headache, or some other symptoms like slurring of speech, or some visual disturbances like diplopia or double vision or blurring of vision, or there may be some kind of weakness of the limbs. So in such case we immediately suspect that the patient might be having some stroke or some central cause of vertigo. In that case we immediately order for a CT scan brain or an MRI brain, or if we suspect some intracranial tumor, etc. So investigations will support our diagnosis, and the treatment will entirely depend on the cause of the vertigo. If it is peripheral vertigo, if it is Bpvp, a simple procedure like Epley's maneuver will take care of the vertigo, and the patient can be cured completely by 1 or 2 sittings of the Epley's maneuver. And then at the same time we prescribe certain labyrinthine sedatives to support the patient during the period of vertigo. That is, we prescribe medicines for 1 week to 2 weeks and ask the patient to take rest, avoid driving, avoid traveling alone, or walking with a support. If the patient is having some imbalance while walking, we ask them not to go out alone, or use a walking stick or take support in case of such a attack of vertigo. If they are driving, we tell them not to drive a car, and if they are driving a two-wheeler, we ask them that if they feel vertigo, then if they feel the feeling of reeling or giddiness, they should stop the vehicle and rest for 5 to 10 minutes till they feel better, and then resume their journey. If it is a cervicogenic cause, then we ask them to do some isometric neck exercises, use a cervical collar for support when they are working, or when they are bending their head or doing other activities. And when they are lying down, we ask them not to use a pillow. We prescribe a cervical pillow, or ask them to use some thin bed sheet or something under their head and neck to avoid any torsion of the neck or excessive flexion of the neck. So these supportive measures will take care of the vertigo. Of course, if it is a central cause of vertigo, then immediately we refer to the neurologist or the neurosurgeon to do the needful. So as you see, friends, that vertigo is not something to be, you should immediately consult an ENT specialist or a neurologist or your primary physician, who will in turn take a proper history, and then will make a diagnosis of the vertigo, and then will refer to the concerned person for further management. And it is something that which can be treated very effectively once we know the diagnosis, and then we can be rest assured that it is not something which is life-threatening or debilitating, and it can be taken care of by a proper measures like medical treatment, or in some cases surgery if required. Thank you. I hope that this talk has been useful to you as common people, or to the primary physician, or to the ENT specialist, and help you in diagnosing this difficult condition called vertigo and managing it effectively. Thank you.